Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
By the way, I did talk with Ramona Robinson, who told me that she lost her transplant kidney and she's back on dialysis. She had some fungus at her house that caused her to lose her transplant kidney, she said. And she also had an accident and lost an eye. And she said she would like to participate in some of our meetings, but her dialysis day is on Thursday, so she's not likely to participate. But I did send her the address for our meeting, and she said she might try to participate in one when she can.
What about Dr. Ivy?
Ivy I got a note from him. He said he's doing fine, and he wished all of us happy Father's Day.
All right.
Yeah.
Oh, well, happy Father's Day, you fathers.
Thank you.
Thank you.
I'll ditto Carol.
Yeah, it's amazing how Father's Day and Mother's Day is so different. Mother's Day, you can't find a seat in the church. Father's Day, you find many seats in the church.
That's because most fathers don't go to church. But anyway, what do you fathers really want?
Nothing.
No, because I ask every year, and that's what all you men say. I say, you know, the ladies, we were going to plan something special. What do you want? And we come up with zero.
Right. Yeah. Being a father is its own reward.
I like
Oh,
that.
that's very philosophical. But okay, give me something tangible.
I just gave you something tangible. You don't want anything.
You don't want anything. Do you want us around, or do you want us trying to throw you a party or cook for you or anything?
You can continue to cook for us, but and cook our special meal if you like. But
okay. Ask you what
about
your
it.
special. Oh, that's a good idea.
Yeah, our special
Treat you
meal.
like a king. Okay.
Yeah, right. Which you do every day anyway. So my
Mhm.
wife treats me like a king every day anyway. So
Oh, wow.
what else can you ask for?
I don't know. It's according to what mood I'm in, right, John?
Doesn't matter.
I treat you like a queen.
Your worst is good enough for me.
What's your special meal, John? I don't know whether I want to come over.
Haven't planned it yet. I know that I'm going out with my cousin on Tuesday evening to celebrate their anniversary. So we might double dip, celebrate little Father's Day that night too.
So he didn't answer your question.
No,
No, he did. He was very evasive.
no.
Right.
I'm glad you noticed that. I told him about that.
Yeah, them answered the question.
John Buchanan, what do you like to eat?
I don't know. I think my favorite meal is breakfast or brunch. I like brunch.
What do you like for
We still
brunch?
are not getting nothing definite.
I know.
What do you like for brunch?
Let's see. I like omelets. I like
Bacon.
chicken, sausage,
Oh, don't let Darryl hear you.
salmon.
Waffles and pancakes.
salmon. I don't really like pancakes that much. I'll eat them, but
What about waffles?
no. Maybe I like crepes sometimes.
Okay, let's start the
Enough food.
show on the road.
Oh, you want some articles? Oh, okay.
Yes.
You ready?
You want to hit me with the first one? How old, how old is too old to practice? That's something we've talked about for quite a while, but they're varying in opinions, and this is an interesting article that takes a very objective perspective on it, because it talks about the age that when the average American retires at 63, which is way younger than the physicians who you can see here require age 70. So 9% quit at 75 or older. And it doesn't really talk about the physicians who practice well into the 80s and the rare ones who practice into the 90s. But the reason for this was that there was an article that pointed out that older doctors had a higher mortality rate among their patients. And so they tried to use this to indicate that older doctors should stop practicing, let the younger doctors practice because their mortality rates were lower. And then there were many reasons as to why the older doctors had the larger mortality rates. And so they concluded that maybe this is because they aren't staying up to date, and that they aren't as agile and they aren't as cognitive as they were before. And so, in short, they recommended that they be tested to identify whether age is interfering with the competence of doctors, and that maybe there should be an age after which doctors should cease to practice. And a lot of it depends upon the discipline, whether you're a surgeon or an internist or a radiologist or a dermatologist. And so we don't have really much basis for doing this. And so the best idea I think that I've read about is that it probably have a standard of identifying, having the physician, their physician, evaluate them from a cognitive as well as other basis, and make recommendations as to whether or not they need to continue to practice or not. And our question is whether it should be mandatory or should it be optional. And so I think the more that we look into this situation and do what's in the best interest of patient safety, the better off we are likely to be. Because pilots undergo routine evaluations, and so should physicians. So the question is, what are the appropriate evaluations, physical as well as cognitive? And they have not yet been established, but this is something that should come first. What are your thoughts about it?
Dr. Callender,
Yes.
yeah, it seems that like you were suggesting, that the different branches of doctors would determine the qualifications for those specific
Specialty.
practices, right? So that the opticians would determine for the opticians, you know.
Well, yeah, actually, technically speaking, yeah, I think that's a great idea. Every specialty should have its own monitoring practices, because what is true for ophthalmologists may not be true for opticians, may not be true for general surgeons or cardiovascular surgeons or neurosurgeons and so forth. And so I think the different specialties ought to have their own way of evaluating their people. And I think the sooner we have that done, the better. Because other than that, you just have somebody talking about what docs should be doing at this age, which is inappropriate because the specialty may not require that. For radiology, it's maybe vastly different than from cardiac surgery and neurosurgery and for transplant surgery. So, and this may be very different for the internist and for the transplant physician. So
I
I think
also
that's a
think
good idea.
I said, I also think the statement that you made about older doctors losing more patients, I think that's really because the patients are probably older because you've had them longer. They're stuck with you and they age along with you. And
That's another possibility as well. And I think all those factors need to be taken into consideration as you make a decision about it. So, but it's a very appropriate discussion and something that the medical field has not been anxious to deal with. And I'll give you the case of the 100-year-old doctor who's doing well, but they don't talk about the other doctors who may not be doing so well. Any other comments as we move on?
Do doctors live longer than ordinary non-doctors?
Well, there's some evidence that, yeah, that the longevity is increased in physicians.
That's not because they can self-medicate, is it?
No, hopefully not, because self-medication is a good way of killing yourself. But I don't know that we really know that well. We do know that the longevity of physicians is longer, but we also knew that we have pockets of physicians who commit suicide more than any other group. So.
Yeah, you told us about the anesthesiologists
And psychiatrists, yeah.
and psychiatrists.
Yeah.
Yeah. Okay, thank you.
Dr. Callender, what about those who, work with, let's say, doctors and they see the signs, but don't say anything? It brings to mind when I had a hairdresser who I would go and get my hair done, and it seemed like she was taking longer than usual when I'd sit in that chair, and her person next to her, she had a client in the chair, and the person was with that new client. She was finishing early, and I heard her say that, "Dang, that young lady is still in the chair." And the girl was next to her said, "Well, they still keep coming." And I was wondering why is it we're so hesitant when we recognize these signs that we don't say? I'm just thinking, if you have a doctor and those who are around him every day don't even mention, "Oh, I see something different."
Well, that's a good question. One of the things that helped us decrease the aviation mortalities, which are next to zero now, is that if you see something, you say something. And people seeing something and saying nothing is almost criminal, because you're right. That's one of the ways you get change. If you see something, you say something. So it's really important to do what you're talking about. If you see signs, then you ought to do something to help that person out and make a decision. But to say nothing means that you'll do nothing, and therefore things will move on. It reminds me of an elderly person who they asked to stop driving because they felt he wasn't safe. She wasn't safe, as a matter of fact. And the next thing you know, she had a fatal accident. So if you don't say something and don't do something, the results may not be so good.
Yes, and then you have to deal with that person's response, when you do
Oh,
say
yeah.
something,
That's
you
right,
know. Mhm,
right. And people are reluctant to change.
mhm,
Uh,
mhm.
So, you raise an issue that in every field, when people see things, they should say something
Mhm.
because
Lamar,
it's all about patient safety.
Yes.
I had a quick question. To whom would you report a doctor?
Oh, well, we have a board. We have a medicine board. That's who you report it to. The medicine board. They have a board of medicine that evaluates all physicians, and this board consists of patients as well as physicians, and consumers as well as physicians, and they make decisions about whether or not a doctor should continue to practice. So that's who you could make a complaint to, and they would review it and then make a decision. The only problem. So if you have a specific complaint, that's what you would do, and they would address the specific complaint and call the doctor in and ask him about it, and then that group would make a decision as to what are the next steps.
Dr. Callender, are there any insurance people on that review board?
No, just
No.
consumers,
Okay.
not insurance people.
Okay.
Dr. Callender, what Sylvia brought up is almost a part of our lives. Sometimes we see people in different careers and we know something is wrong or something and they shouldn't be doing that anymore. But the problem is just who do you report it to? Because if you tell it to that person or you tell it to that family, they don't want to hurt their feelings or they're in denial or something. And it's futile. Now you got an arch enemy instead of trying to help somebody. Because I know once there was a pastor and everybody knew that he had dementia, but nobody wanted to even say it aloud. And if you said it out loud, they act like you committed a crime.
Well, how do you handle it in music? You have singers who no longer can sing, and what do you do?
I'm gonna let Bonnie answer that, but most of the time, musicians can, if they got friends around them, they know how, the audience will stop coming listening to them, or they get a premonition, especially pianists, that they can't really hit the licks like they used to hit, and they know that their art is gone. But for the ones that are in church and sing, there's no way you can tell them that they can't sing because everybody in that congregation told them that they could sing. They just have to go out into the world where people got to pay money to hear them sing, and then they'll be broke. But Bonnie, how do musicians, vocalists or something?
When you hear a voice change, then you have to change the voice. For instance, if a person has been, let's say a tenor, and the voice changes and they have it's lower now, then you might suggest to them that they go to the baritone and just try them out. But I wouldn't, seasoned people, you just don't want to throw them out. But you work with the voice as it changes and make suggestions. And some of them will receive it, of course, and some of them will still determine that they are lyric soprano. I was once a lyric soprano, but now I know I'm no longer lyric. Every once in a while I can, and I realize that. So that's what you do. You just have to work with them and keep them encouraged not to give up.
Well, that's an interesting perspective. But you see, the difference is that in music, if you sing the wrong note, nobody really is going to be hurt. In the practice of medicine and some of these specialties, If you do the wrong thing, somebody will be hurt, and that's the difference. And,
Mhm.
you know, and I say that to people all the time. You know, if I hit the wrong note, so what? Who cares? I mean, it may be a little painful to the ear, to the musician, but that's the worst that will happen. Whereas if you're in the field of medicine or some other specialty, patient safety is at risk, and so it's important that something be said, unlike in music. But John, what about you and your instruments? And the both Johns, you both instrumentalists, and Darryl, you are a singer. What are your thoughts?
My thoughts are that with piano players, sometimes they develop carpal tunnel syndrome or neuropathy in their hands, or maybe even a stroke on the left side or the right side of their body. And then they all of a sudden they look up and their fingers aren't moving the way that they were. And they might have to change how they play the piano, or they might have to just play with one hand.
So what you're saying is, in music, nobody's going to stop you. That's what you're saying.
Well, they stop themselves, is what I'm saying.
You hope. You hope, right?
No,
Okay.
I know of an example where a guy had a stroke and, it affected his left hand. And so he was not able to do the things that he used to do with his left hand. So he would kind of play with his right hand and kind of fake it with his left hand.
Yeah, that's unfortunate. Okay, Buchanan, any thoughts on that? Or Darryl?
Yeah, I know that as I age, my memory does not work like it used to. We used to be able to play, a 4-hour gig from memory. Now, if I didn't have my iPad and put my charts in front of me,
Mhm.
I would be lost. So that's one of the things. And somebody who can't remember the music probably won't get hired in the future. So that could be another thing with doctors. I mean, this is what we're talking about, though. Something that could be life and death for somebody. You don't want to mess around with somebody's life when someone's life is on the line.
Well,
Darryl, any
here's my
comments?
here's my thoughts about it. There's a lot of horn players out there. I got a cousin, Bill Simmons, with Midnight Star, and in their heyday, he was a sax player. Uh, as time went on, he became their keyboard player, playing horn parts on keyboards. So, and I think John, you play keyboards too, right, John Buchanan, as a
I do.
trombone player, right?
I do.
So that's a way of keeping yourself current. There's a lot of musicians these days who will. There's a lot of artists that will no longer be current. Like there's a Hollywood writer's strike, and they're striking because they don't want to get fired because they're getting replaced by artificial intelligence. But there's a lot of musicians that'll have to transfer over to from being performing artists to being artificial intelligence prompters. That becomes a new art form. In medicine, I think there's a lot of doctors that are working with artificial intelligence apps. I prefer a doctor with experience, but I think that if that experienced older doctor is also working with artificial intelligence, that's the best of both worlds. But things are definitely transitioning, and there's a lot of artists that are going to lose skills just because of aging. But if they can transition to, there's a lot of arts in the future. 50 years from now, there's going to be far less performing arts. There's going to be a lot more music that's generated by artificial intelligence. There's a lot of songs written by artificial intelligence, a lot of movies, videos, all created by artificial intelligence. It's going to need fewer creators, but it's going to need people that know how to prompt and manipulate artificial intelligence. It's just the way the world is heading.
Well, thank you. Anybody else want to make a comment before we move to the next article?
Dr. Callender, I was just thinking sometimes with vocalists, you may want to try them when you notice a voice change. You might want to give them a solo part and put them where they really need to be now. And you can, ease them into that change, because some people just don't want to accept the fact that they are no longer the same. So you don't want to throw them out, but you just ease them into it.
Why don't you want to throw them out?
You don't want to, I mean, really don't want to hurt anyone's feeling, especially in the church. For instance, at my church, there is a young lady who loves to sing, and trust me, she absolutely, positively cannot sing. She is totally, totally, and completely tone deaf, but she loves to sing. But she also loves to write. So I talked to the pastor about it. She doesn't want to throw her out, neither do I. But I said, since she likes to write, let her write a poem and use her there. But she still loves to sing. So what are you going to do? I
It's
tell her,
an
don't
easy
sing
decision
so
for me.
loud now, you're overpowering everybody else. You just
Just
have
tell
to
her to
learn
stop
how to
singing.
work with them.
Tell her to stop singing.
Yeah, well, I've tried that too.
Oh,
Not
well,
like
then-
that. I didn't say stop singing, but
Well, yeah, but that's an option. Okay. Maybe a cruel one. But
I'm back again. I think it's because of hurting people's feelings,
Mhm.
but especially if they're older. But it does create something. I was at a convention and a lady that was 93 years old went on the stage, and everybody just started clapping and cheering because she was 93, not because she could sing. So anything she sounded like, they encouraged her because she was 93. And that's not what we should do, but we as human beings, we do it because the lady, she just sounded okay. It wasn't nothing extraordinary, but they were doing that. And we tend to do that with almost in every field, including physicians, because we say we don't respect age, but yet we do. And sometimes
Yes, we do.
people just need to give it up because you're not really helping anything. But hope John don't mind this. When he got his pacemaker the first time, we had this doctor, and I don't know, John can tell me whether he was young or old. He said, don't wear a sling. So when he got it the second time, they're saying, get a sling. And even the nurses and everything, what, you don't have a sling? Well, this doctor said, no sling, no this, or that. And the orders were completely different. And I don't know if he was young or old, but even the nurses, they had a question mark and they wanted us to question, but we didn't know that we should question what this physician was giving. So it was just bringing up a fact. When they do something out of the ordinary and everybody else has a question and the patient is not, now sometimes you should say, I need a second opinion right then before you leave. I don't, so, but that just
Okay.
happened recently.
It's a difficult thing.
Elizabeth, you want to say something?
yes. Again, good morning, everyone. Yes. When we think about this, we think about complaint versus concern. And how do we handle complaint versus concern? And it does depend on the profession, because by me working 20 years in medical, I love older doctors. I love them for their wisdom. I always had to work with the medical director. So I love them for their wisdom, their knowledge, and their experience. But the concern is when it becomes a life and death. And that hit the top of the list. But from experience in the teaching profession, we run across, and even in our daily lives, we run across people that we see that are changing. I saw a choir member. She had a solo, and she got to the first sentence and she couldn't remember the second sentence, and they handed her a piece of paper. And she had problems concentrating on the paper and trying to sing. So there's circumstances that like when my mama changed, she said she confided in me more than she did to others. And she said, something is happening. I don't know what it is, but something is happening. I'm not thinking like I should, et cetera, you know. But going back to teaching and wrapping it up, teaching is one of those professions. Now, my son experienced something when he was in elementary school. He came home one day and he talked about his teaching and how she was changing and things that was happening that he observed in the classroom. He said the other kids didn't observe, but he observed. And so he asked me what to do. I said, well, tell me what's happening. He explained. And I said, okay, what I want you to do is to help her. Help her. And he said, she's always looking for papers, Mom. When she get ready to teach, she's always looking for paper. And I said, well, what did you do today after the discussion? He says, I went to her basket. I knew where she had placed that paper, and I pulled it out and says, Miss So-and-so, are you looking for this? And she said, thank you. And she told my son, thank you. I just love you. I just love you. But because he helped her, the next year she retired.
Okay, any other comments? If not, let's go to the next article. Thank you. Yeah. Wow. That's interesting that those questions persist and the answers are difficult. As we all care for one another, we have to do it with love. And I think that's what you guys are saying finally, that try to do whatever you do with love. And except in the life and death situations where those changes matter more than whether you can sing or can't sing. Well, this is an article that shows, it's interesting. Darryl talked about changes, and we're changing in everything in medicine, things that we couldn't do in the past, we now do. And this is a heart transplant, and in the past we had to use hearts from people whose brains were dead, but the hearts were still beating. And now we have ways in which we can perfuse hearts so that we can take hearts from people who have had circulatory death where the heart says stop beating, and we can restart it and find that the results in transplantation after they've been restarted, it is as good as those people for whom the heart was still beating. And that's what this article is all about, indicating that after the heart stops beating, that it can be reanimated and used successfully, and that you can have a heart transplant from somebody who's brain dead and somebody who also, whose heart has just stopped beating. And that we have now ways of recirculating and reanimating those hearts so they can be successfully transplanted. In addition to which, we now have ways of using cold temperatures and warming temperatures that allow us to make some organs that weren't so good before better, so that we now have ways of using organs for transplantation that we couldn't use before. And that's in essence what this is all about, that, or just as Darryl talked about artificial intelligence being important, we also have other things that are occurring in medicine that make what was difficult or impossible before possible. And this just then is what we're talking about, so that the reanimation process is active in transplantation as it is in every other field of medicine and outside of the field of medicine. Any comments on this article? I put in just for us to keep in mind that that we're changing, and many things we couldn't do before we can do now. But the number one cause of problems in transplantation is still the shortage of donors. The discrepancy between those who are waiting over 100,000 and those who actually are transplanted, about 40,000, still is the biggest problem of transplantation today. Oh, so
Dr.
Councilman,
Callender,
yes,
if someone that has dementia or Alzheimer's, are they able to donate a organ?
yes,
Okay,
simple yes.
okay.
As long as they don't have active infection or cancer, yes, they can be donors. Now, this is just something that I thought I'd address because they call this list diving. In other words, on the transplant list, when your name comes up at the top of the list and the kidney is offered to a center, they can actually say yes or no. And they can say yes to the top person and go to somebody below. But there are a number of reasons why they may want to do this. One of the reasons might be that the patient is sick, or there may be reason that the patient no longer wants the organ. But one thing that is clear, though, is that when the organ is offered, the center has the option to use it or not use it, and to use it on the patient it was sent for, or to use it on another patient. And because of this, it's difficult to give a reason for why, when I send an organ to you and you use it for another patient, why that happened. And so for that reason, it becomes list diving is something that one has to get some answers to the question, because the list diving, as they call it, may well be in the best interest of the patient. But then again, it might be in the best interest of the center and not the patient. And so that's why the practice of list diving makes one wonder about why a transplant center would accept an organ and then give it to somebody who's lower down on the list. But there may be legitimate reasons for this, but there's still a lot of subjectivity involved in transplantation. Yeah, we have a computer list and we have the theoretically artificial intelligence that says where the organ should go. That isn't always where it goes, because the transplant center may make a decision which is in the best interest of other patients. Any of you who have any comments or questions about the waiting list that is there for the computer to identify the person who is likely to be the best donor? And the best donor is the person who has the best match. You have about 6 antigens that are common between the donor and recipient. And if you have more, if you have 6 antigen match, that's the perfect match. And if you have only 1 out of 6, that's less perfect. But in kidney transplantation, a 1 antigen match may have a long-term survival, although the 6 antigen match would have the best survival. Any question about the system for sharing organs? Because that's what this is all about. And there's been a lot of discussion recently about the sharing of organs.
Dr. Callender, I thought that the patient goes on the list, not the center, but
that's not correct. The patient goes on the list, but the offer goes to the center. The center can then decide to use that recipient or not, based upon circumstances. For example, kidney may be offered to that patient, but that patient may say, I don't want it, I'm not ready for it right now. Or the patient may be sick, or the patient may have other circumstances, in which case it would go to the next person down the list. So while it may be offered to that patient, the transplant center makes the decision as to whether or not that patient is suitable for the transplant.
I understand.
And
John,
sometimes it may be in the best interest to not give it to that patient because the patient is not ready. But in many instances, that might be the patient's decision, but in some instances, it's the physician's decision.
John Tatum, didn't something occur when you got your first transplant that you weren't at the top, but the person,
No, he was at the top. We couldn't find him.
oh, I thought the other person couldn't be found. That, yeah, the first,
John couldn't be found.
oh, I
He was
thought it
at
was,
the beach.
I thought it was the other way around, that the
No.
first person couldn't be found. but
No, we
John
couldn't find
be
him. We
found.
finally found him. But
Oh,
it's,
okay.
wow.
I knew it was something.
The story goes like this. There was another person on the top of the list. It was a physician. And they told him to come to get the kidney, but he was farther away than I was. And so they gave me the kidney. And it, he was really sad, understandably, when he got to town. They said that you got here too late. We'll have to give it to someone else. I forgot the doctor's name.
Well, that's a
Dr.
good-
Baptiste.
Dr. Baptiste. Yeah.
But that's a good reason, for example, why the doctor may decide not to give it to the person who's on the top of the list because they're not available.
Yeah, that's why I wanted to bring that out. I knew it was something. I remember the story.
They may
And
not
then
be
the other
available.
story
They may not be
is-
available, or they may not even want it because we have circumstances in which the patient say, "Oh, I'm not ready now."
Mhm, mhm.
And then the other situation, of course, most of you know that my son Mark, who's on the line, he was the first to be able to offer his kidney. And the problem was that even though he was a antigen match, a very good antigen match, that kidney rejected after 1 week of service. So that was very sad for the whole family. But the good side is Mark is doing well. He's on the line, and he's doing very well.
Technically not the first to offer it. I think I was the first match though to offer, because other people had stepped up and tried, but I think I was the first one to be a match. Is that correct, Dad?
Yeah, that's
Yeah.
correct, because Carol offered, but she had high blood pressure. My brother offered, but he had a tinge of hepatitis C. But the good thing about that story is that he didn't realize he had hep C. So he was able to go ahead and get that eradicated because the new medicine was out. And so he had to take it for 6 months. And then his hep C was under control. My brother Kevin.
Okay.
Okay, any other comments you want to make about this? We'll go to the next one then, next article. This is xenotransplantation. Xenotransplantation means that we're taking organs from other species and using them for humans, whether they're pigs, monkeys, whatever. Right now, because of HIV, I think most people are afraid of using the primate model, which would be the model that we ordinarily had thought we would use. And for that reason, we are really thinking of using the pig as the model of choice for transplant. And of course, this becomes an issue because we've got this disparity of the shortage of donors, and the consequence of which 17 people are dying every single day because of the shortage of donors. And so one way to overcome this is to get organs from other species, like the pig, or to grow organs. So those are the two options. And xenotransplantation is an option that has been unsuccessful in the past. But with the advance of medicine, we now have genetic modifications that allow us to have pigs that no longer are rejected because we take out that specific antigen that is causing rejection. And so we then create pigs that no longer have that antigen. And this then allows for us to have successful transplantation, or at least we eventually expect to have a situation where we can have successful transplants between organs from other species and humans. And the number one prospect right now is the pig because they have organs that are similar in size to those of humans. And so the question comes up, well, when will it be okay to proceed with transplantation of organs from non-humans? And the question is, when will we be able to do it safely? And what will other people say about the process? Will they think it's safe to do, willing to do, or will it be like the COVID vaccine? Will there be so much distrust and fear that they won't do it? And so this then question is, are we ready for a xenotransplantation? And this doctor says yes. And we're getting close, but we haven't yet done, of course, we did do a human heart xenotransplant last year. And the result was that the heart lived for some days, I think 2 weeks, then the patient died. So we are now in the position that we're about ready to have clinical trials for xenotransplants. The question is, what is your thought about it? Would you accept a non-human organ to save your life?
Yes.
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 Anybody would say no?
I would have to think about it a couple of times.
Me too. This is Sylvia.
Okay, any reason, anybody would say no? You're thinking about it, but would you say no?
I might say no.
Why would you say no?
I don't know. It's just the mindset of an animal. Matter of fact, I still have a problem like when my husband eats venison, I say, poor Bambi. So I think it's just a mindset. So it's something that when you approach, it's a matter of doing the research and trying to gain as much information as you can so that you can alter the way you think about things. So
well, we're doing using heart valves all the time. So right now we're doing tissue xenotransplant every day because we're putting heart valves.
For me, I would want to know the animal's name, where they came from, where they were grass fed, if they have a mother and father. I need more research.
well, that's what I'm saying. It's a matter of doing your research and gaining as much information as you can about this type of transplant. But it's as I said, it's a mindset. I can't even eat as I said, deer meat because I said poor Bambi, and as I said, it's just a mindset.
Oh, any other comments about xenotransplant? Of course, the other reason that it's taking so long to do xenotransplants is because of xenozoonosis, the fact that HIV, of course, is a disease in which the primate model virus was transmitted to the human, and that caused HIV. So we have to be sure that the animals we use have to be germ-free and virus-free. So those are other concerns. Any other thoughts, comments you want to make about the possibility of xenotransplant? Because this is something that in the next 5 to 10 years will become an issue. But because of the fact that 15 people are dying every day because of the shortage of organs, it becomes an issue that it becomes very important to address.
Dr. Callender, one of the other issues is that if it's a life and death situation, it's a matter of, do you want to live longer or you want to just bail out? But for people who are on dialysis because of kidney failure, they may say, well, I'll just stay on dialysis.
Yeah, they have an option. Whereas for the liver and some other organs, there is no option. So, but you're right. For the kidney, you can always stay on dialysis. That's an option that kidney patients have that many other patients don't have. Okay, it's an interesting subject that we're going to be dealing with from now on for the next 5 to 10 years. And actually, one of the things is that there's no religious reason for not accepting xenotransplant. Most religions think that to save a life, and as long as the organ is free of blood, that the transplant could be done. Now, this is another article that I thought would be important to share. We talked about the fact that we now recognize that women with dense breasts have to have special supplemental tests to ensure that they don't have breast cancer. But when this is offered to many women, they are not willing to have the additional ultrasounds or other types of breast tests, screens, in order to find out whether the dense breasts are hiding a cancer. And this was a little surprising because it was expected that people would take advantage of this and get the ultrasound or whatever else is necessary to identify whether the dense breasts were hiding an unsuspected cancer. And so it's very important here, as you had talked about a mindset. It's important for women to have the mindset that if they have dense breasts, that the standard mammography testing may not be sufficient in order to identify a cancer that is in the breast. Any thought about why women would not proceed to get this additional screening, which is recommended for people who have dense breasts?
The only reason I could think of is that maybe the insurance wouldn't pay for it, but other than that.
Well, that's not the reason.
Okay, so I don't see why they wouldn't. And I know
Do they know? Did the doctors tell them? Because
Yes.
nobody's ever told me anything about my breast.
Well, but this is now, okay. In the past, that was not a requirement.
Yeah.
This is now a requirement that the doctor tells you you have dense breasts and therefore you need to have supplemental x-rays, ultrasounds, and other tests. And so then, yeah, you're right. In the past, it was not told. But as of this year, all patients, as of last year, all patients who had mammograms, if they had dense breasts, they were told that they have dense breasts and therefore they need additional testing to be sure that the dense breasts are not hiding a cancer. So it's after they're told, a number of them still have not gone on to get the testing.
Well, Black women are more likely to have dense breasts, or have physicians been recommending to Black women that they have the supplemental tests?
Yes. As I said, as of last year. Yeah. This is new. So, yes.
Yeah, that's what I was going to say. I know African-American women have more density to their breasts usually.
Right, so it's something that our people need to be more understanding of and comfortable with, and proceed to get the supplemental ultrasound screening that is necessary.
And the ultrasound definitely cannot be as painful as the original mammogram. So I don't
You
know
ain't
why
kidding.
they would want to.
That's correct.
Want to. Yeah, I don't know why they would not want to go there.
Well, okay, well, anyway, it's
know.
important to educate our people about this so that when they're offered the ultrasounds, that they proceed to get them done. Because
Last year,
that is-
when I had my test and I got my results back, my results indicated just that. So I'm glad we're having this conversation. So when it's time for me to have my next checkup, I will talk with my doctor about having the ultrasound.
Yeah. Okay, any other comments? If not, it's important to share this information with your children and grandchildren and great-grandchildren as it's appropriate. This is an article that we may have talked about before. When to come out of COVID isolation. COVID is still with us. I just talked to one of my doctor friends who went to a conference, same conference I went to in San Diego, and now is COVID positive and has COVID. So people are still getting COVID. So the question is, when should you come out? And remember, one time it was 10 days. Now it's back to 5 days, and there's a lot of discussion. It seems, though, that the 5-day period is what most people have agreed upon, especially if you're no longer symptomatic and you test negative. It's safe to come out, be sure. But I think in general, as long as you're symptomatic, you need to stay home. Okay. And then if after you're asymptomatic and you're negative, I think it's safe to come out. So 5 days is what most people are suggesting. I think everybody is clear on the first 3 to 4 days you are contagious. So, but it's after 5 days that if the test is negative. Now we have some people who after 5 days the test is still positive. So that's different. Any comment about that? If not, they remind us if you're sick, stay home. And that's probably the best advice. We've talked about exercise ad nauseum, I think, but it's never too late. So, for example, they did this test on 70 and 80-year-olds walking 4 days a week. And they were pleased to find out that the cognitive test improved as they exercised. So even older brains can change with exercise. So never too old to start exercising. So 70 and 80-year-old, as they were able to do these tests on and to confirm the fact that their cognitive abilities increased as they exercised. So keep that in mind as you approach those ages of 70 and 80. It's amazing how exercise helps everything. Any comments? If not, we'll go on to the next one. I think that's interesting. What does it mean for younger brains? It means that even more likely for you to, it's important for you to start young, but if you can't, start old. Now, remember, we talked about multivitamins many times, and it has been clear that multivitamins in general, if you're not vitamin deficient, don't really do much to help. But we're now getting more tests that indicate that they do boost memory in older people, which is it's about the second article we've had on this subject. It points out that multivitamins do help the cognition. And it's going to be interesting over time to see if this holds up under scrutiny. But so far, multivitamins, we found a place for multivitamins at last in terms of helping our brains function better as we age. Any comments about this? Any of you multivitamin tablet takers?
Yes.
I take them.
I used to take them, and then you said don't take them anymore.
Yes,
Yes.
yes, I take them. Yes,
So I'm gonna
I
start back
take
up again.
specific ones.
yes,
Well, if you have a vitamin deficiency, you should take them. But this
yes.
is saying that regardless whether you have vitamin deficiency or not, they're good for the brain and your memory. So, and as
Both
we
of my
age,
parents,
go ahead, Darryl.
both of my parents wasted many thousands of dollars on Shackley multivitamins.
Yeah. Yeah, it's $1 billion industry. Yeah.
I take specific vitamins. I don't
Yeah,
take
me
a
too.
pill that has all kinds of vitamins in it. I don't do that. I just specific vitamins that I need, that I'm deficient in. Those are the ones I take.
Yeah, and this article says that multivitamins help for memory in the old ones, whether you have deficient or not. But anyway, it's interesting article, and time will tell whether it stands the test of time. Now, this is another medication that they have for Alzheimer's. Now, the only thing that is problematic about these medications for Alzheimer's is that they don't eliminate Alzheimer's. They try to delay the progression of Alzheimer's. And I think that's something to start with until we get a drug that actually cures Alzheimer's. And the data suggests that this medication, after double-blind studies, including almost 2,000 patients, whose mean age was 71, but I think there's something to notice. And it's good to hear that they're recognizing that many of their studies are underrepresented for Black people. Only 3% of Black people were in this study. And that used to often be the case. So that we never knew whether the data that they presented was appropriate for Black people or not. This one, however, was underrepresented. But it did show that there was a delay in progression. Didn't say it cured Alzheimer's, but it did say it delayed the progression of Alzheimer's with a highly statistically significant fashion. And so for this reason, the FDA approved this medication. Any comment about this? You know, we had, I think, Flavia Walton was with us the last time, had a discussion on a new drug of treatment for Alzheimer's.
Do you
And
need
it
a
was-
prescription for the drug, or can you just?
Of course,
That's what.
of course, yes,
Mhm.
absolutely. And FDA has just approved it, so it would take time, but yeah.
I remember when my mom had a diagnosis of Alzheimer's, and she was taking the medication, the only medication that they had at the time. This was 6 or 7 years ago, and they said that it would slow the progression. But to me, just that thought, how can they measure, that it would actually
They do.
slow progression?
Well, because they do tests. They do cognitive tests that measure your ability to remember or not remember. And I think that's what they did in these patients. And that's how they were able to identify that there was a delay in the progression of the Alzheimer's. Whereas in those patients, the control patients, there was not a delay in the progression of Alzheimer's.
Okay.
So it's going to be interesting to see, but it was clear that in those other medications were useless for the most part. And so if you asked any physician, they would tell you that there wasn't enough data to suggest that they were very helpful. And you find a few patients who said that they were a little better, but most studies indicated that the medications we had in the past were not capable of doing what this drug has done. Although, again, this does not cure it, but it does attempt to delay progression of Alzheimer's.
A medicine that comes to mind that my father-in-law took was Zoloft. You remember Zoloft, Dr. Callender?
Of course,
Yeah.
but we didn't really help anything with Alzheimer's. Did it help your father-in-law?
Not really.
Yeah, that was true of most of the medication that they used for Alzheimer's. This is an article about Splenda. I don't know how many people use diabetics. Kind of forced to use sugar substitutes, and Splenda is one of them. And sucralose is the name for it. And there are a number of articles that in the past have said that Splenda is useful and is not associated with any toxic side effects. And these recent studies suggest that is not exactly the case, and that there is mounting evidence that Splenda may have some side effects. And so this article is questioning whether it's safe to continue to use Splenda, which is sweeter than sugar, but it can be toxic under certain circumstances. And these are the data that in the past were given us. And they now have done tests that suggest that Splenda is not, that it is metabolizable. And most of the previous data said it was not metabolizable, and that it would not be broken down. It would come out just the same way it went in. But more recent tests are suggesting that is not exactly true. But of course, there'll be other tests that will be done. But right now, there are a number of evidences that Splenda may be metabolized into products that may not be as harmless as Splenda. And if you use sweets, sugar replacement therapy for your diabetes, this kind of things, because there are a number of sugar substitutes that they have. Okay, well, just wanted to make you aware that Splenda is now under investigation. Go to the next one, please. This is an article that gentle cleansers kill viruses as effectively as harsh soaps. It's interesting because alcohol has caused so much skin unfriendly consequences that people wanted to use gentler soaps. And they're now identifying that just about all the soaps kill the virus. So you don't have to use the alcohol, which may be hard for some skins to take without being irritating to the skins. So soap and water for 20 seconds is all you need. You don't have to have alcohol.
Dr. Callender talks about envelope viruses and non-envelope viruses. What's the difference?
I don't know what an envelope virus is. And that's the question. I don't know the answer to that. But I know that a number of people who had contact dermatitis as a consequence of the alcohol. Not a large percent, but a number of people. But it seems though the coronavirus is killed by the hand washing of soap and water. That is an interesting article because multiple sclerosis still is not completely reversible. Multiple sclerosis is a disease that affects the nervous system, and it can be devastating, or it can be mild, it can be acute, it can be chronic. And trying to find medications that effectively will use steroids and a number of other monoclonal antibodies that have been effective in many patients in stabilizing it, but they now have identified a compound which clemastine is the name of it, which actually the brain tests demonstrate that it positively affects the brain cells, and the demyelinating process that is toxic is reversed by this product. Now, that product has not yet been used on the market, but has been used in research. And so the hope is that this down the road will result in a medication which will reverse the signs and symptoms of multiple sclerosis in most patients. So for right now, monoclonal antibodies and steroids have been able to reverse it for many patients. But still you have conditions in which the multiple sclerosis disappears and then it comes back again. And sometimes it becomes in a fashion that actually results in the death of the patient. So it's a disease that it's an auto antibody disease in which your own antibodies are attacking you. This proposes that down the road there will be help, additional help, although we have many patients who are on monoclonal antibodies who are able to work and do just fine in spite of having a diagnosis of multiple sclerosis. But the thing about multiple sclerosis is that it comes and goes, and it has times in which it is active and times in which it is inactive. Do you know anybody with multiple sclerosis?
Yes.
Yes. I have a
And-
niece. But she,
I have two friends with MS.
Yeah, and with the medication that we have now, some are very able to work full time because of the medications we have.
Dr. Callender, what is infusion? What does that mean?
Means that you give something intravenously, usually. There are ways of giving medication by a number of mechanisms. But the commonest way is by giving it through the vein.
I don't really know what medication my niece is on, but if you didn't know she had multiple sclerosis, you wouldn't, you actually didn't know she had been diagnosed with it.
Yeah, the medication that they give now are much more effective than they used to be.
Yeah.
They have special monoclonal antibodies that seem to, as you said, reduce most of the symptoms. There's so many symptoms that they have, some that are discernible by others and some aren't.
Yeah. Only thing she complains about, it breaks her face out, whatever medication she's taking, but
Yeah, I see.
doesn't have anything to do with the disease itself.
Yeah. Okay, let's go to the next one.
While we're going to the next one, I was just doing some research on enveloped and non-enveloped viruses. And most of the viruses are enveloped. The non-enveloped viruses are relatively rare. They're more virulent. When they do strike, for examples, like norovirus, paravirus, and I remember hearing about those on cruise ships where a lot of people got sick, like the norovirus is called the winter vomiting virus. It's usually spread by fecal oral route. And so you've got some people on a ship crew that are in food prep, but they're not taking cleanliness measures. But bottom line is that with most normal soap, that can prevent the transmission of viruses with just normal soap. You don't have to go to the harsher cleansers.
Thank you, Darryl. Okay, this is an article on Ozempic, which is a common medication that is actually used in the treatment of diabetes, but it also reduces alcohol dependence. So for alcoholics, this is something that some people who are diabetics notice, that their desire for drinking alcohol reduced. And so there's a suggestion that this could be helpful. We have a number of physicians and other people who are alcohol addicts. And the difference is that for alcohol addicts, one drink forces you to take about 20 drinks. And so it's not safe to take even one drink. So for those candidates, this kind of medication may be helpful. Some people don't recognize that alcoholism is a disease that makes it impossible for you to take one drink. And so while they mean well when they talk about one drink is good for the stomach's sake, is okay, but it's not good for alcoholics, because one drink is all they need to go back into alcoholism. And so this drug may be a drug that is used for diabetes, is also used for weight loss as well. And now also has an effect on reducing alcohol. It's just interesting observation. So. Now, I thought this was an interesting development because ever since Trump was president, he tried to eradicate all of the Obamacare. and still court battles. And so there was a recent battle about preventive aspects of Obamacare, and they approved cost-free preventive care coverage for Americans. I'm sure Trump won't like this, but he's got enough trouble on his own that they won't have to worry about it. But this is something that really has forced the United States to really look bad. The fact that we don't have healthcare as a right for all Americans. And this was a step in that direction, but not step enough in that direction in terms of making preventive care available. And so the courts, they came up with a settlement that allowed the preventive care aspect of the Obamacare to persist. So allow people to get their mammograms and screens free of charge. So that's good to know that there's still some hope. Now, I put this article in here because NASH is non-alcoholic steroid hepatitis, which is actually effectively treated only by liver transplant. So you have the non-alcoholic fatty liver disease, which is reversible, but you have NASH, which is irreversible. And once you get NASH, that means your liver is shot and you're going to need a transplant. Well, they now have a new medication that reduces liver fat by 65%, which has never before occurred, which means they may have a medical treatment for non-alcoholic hepatic disease, which is heretofore been irreversible and treatable only by a liver transplant. So I thought it was food for thought and encouragement that down the road we will eventually have a medication that will allow us to treat NASH, which in the past has been irreversible. So I thought it was a good sign for the future, and that we know we can reverse the non-alcoholic fatty liver disease, but in the past nothing has been successful in reversing NASH. So that's hope for the future anyway. I thought just let you know that down the road we may be able to cure a disease that was actually non-curable except by liver transplant. Okay, I won't dwell on that. Just now, this is something that you need to know, that they have a technique of evaluating your calcium in your arteries, and especially your coronary arteries. And if you have a score of more than 300, it suggests that you have arteriosclerotic vascular disease. And of course, this is brought to the fore because I think John Buchanan was given that diagnosis without any explanation. And so they do not have a test that looks at the coronary arteries, which he did not have, by the way, and scores, and then allows you to effectively say whether you have arteriosclerotic disease or not. And nowadays, with this done, and this becomes important because if you have a score that's greater than 300 and you have to be put to sleep, it's important for them to be aware of the fact that you have arteriosclerotic disease, so that they can take the steps necessary to not make things any worse. So I just pointed out that we now have a test that has already been available, but it can be used to actually give you a score your calcium score of how much your blood vessels are calcified. And that can let your physician know what additional steps can be done in your management because you have a score of greater than 100. And of course, the treatment would be better control of your lipids, normalizing your blood pressure, and perhaps whether or not you need to be on aspirin therapy. These are things that come to fore in terms of knowing about your own health and about your calcium score. So as we add this to a number of things that we need to know about ourselves as we age and we get tested. Any comments or questions about this?
Is that a test that would normally be done? Would I have to ask my doctor to take that test?
You'd have to ask your doctor because since he's made that diagnosis, you might ask him whether he's done that or whether he's going to do that or whether he wants to do it. Yeah, you'd have to ask your doctor because usually it's done on people whom they know you have, you've got high blood pressure and you've got some other problems. And you want to evaluate if you're going to have a surgery, you're going to have any special procedure, then knowing what your calcium score is good to know. But yes, you'd have to ask your doctor for it.
Thank you.
This is something that's well known to us, that medical students are not showing up to class. I'd say 10 to 15% of the students show up to class. And what does this say about the future of medical students and who become doctors later on? Are they going to be as knowledgeable as the doctors who went to class and asked questions? That's a good question. I don't know the answer, but it is an observation that has been developing over the last 10 to 15 years, where students, only about 10 to 15% of students go to class. And of course, they don't go to class, they can't answer questions, ask questions, and they can't get answers to questions. So I don't think it's a good sign, but it is as it is.
Dr. Callender, I imagine that the medical students that show up for class and sleep through the class are the same as people who didn't attend class at all.
I can't answer that question because I don't know. I don't think they've been tested. It's a presumption if you go to class that you participate in the class and you don't sleep during the lecture. So they haven't been tested, so I can't answer that question.
Dr. Callender, I noticed it says they opt to listen to the recording at their own convenient time.
That's what they allege.
This is why I stick with an older doctor.
Well, I if you can't ask questions, how do you know they really understand? And it's undesirable to have that happen. And there's some schools, I think, that are getting to the point where they require you to attend lectures. But this is a nationwide phenomenon that students aren't attending. I don't know about other disciplines. How about in your music schools and other things? Do they attend class?
I can talk about one issue. Music students at IU had to attend a certain number of recitals and concerts. And so they would give you your card and they would have to punch a hole in your card to prove that you attended.
Ah.
So, and then you had to, of course, turn that card in and you have to have a certain number of recitals that you attended in order to pass the class. So
really,
hole punching was the issue.
Yeah, interesting. Any other comments on other disciplines, other professions? Interesting. Well, we may have to start doing that in medicine. I don't know. And it's one thing. It's depressing to the presenter. You have a class of 100 students, and 10 people show up, maybe. Yeah, and so it makes you think twice about what's happening with the other 90 students who allege they're looking at the video. There's no demonstration that they have actually looked at the videos. It's the allegation that they will. So, and then of course, now I think this is important. They have USMLE Step 1 exam that tests you, and you have USMLE Step 2 that tests you as well. So, and if you don't pass those tests, you can't be licensed. So this is a double check in a sense.
Dr. Callender, down the road, what does the medical profession feel that, what kind of threat does the medical profession believe that AI is going to have on its profession?
I think it's being an adjunct. That's the expectation. It'll be an adjunct. It won't eliminate physicians. It will help physicians to be better physicians. As long as, for example, one of the things that they are doing now is they have the, where you go to see the physician, you have somebody who takes the notes so that the physician isn't looking at the computer and he's looking at the patient, so that I wouldn't expect AI to replace the physician. I expect the AI to help him utilize his time with the patient optimally and help him become a better physician. That's our hope for the future. Now, the reason that I say that is because the number of physicians necessary to take care of the needs of the patient population is going to be drastically reduced, because and therefore the need for physician assistants and AI to help keep up with the need is going to be necessary. So I believe that AI is going to be an adjunct to medicine, and especially in rural areas. Maybe not so much in urban areas, but especially in rural areas. Any other thoughts about that?
Dr. Callender, in the legal field, it's not going to replace lawyers, even though sometimes AI is, very helpful. But the bottom line is that if you present evidence by way of AI, the judge can always throw it out. The judge has the last word.
Okay, I guess we can. I guess one more. This will be the last one. This is interesting because it talks about COVID and the menopause. And it appeared that those people who had menopause appeared to have more serious complications, but is it the menopause that makes it, or is it the long COVID? And so one of the things they noticed is that the estrogen and testosterone levels appeared to be lower in those patients. And whether this is cause or effect, still not clear. And many of the studies were done in the UK. I'm not sure they're applicable to the United States, but long COVID has been a problem. It seems that it doesn't occur as often with people who are adequately immunized, have taken the vaccines. But these are some of the most important symptoms that they found in these people with long COVID. Always tired, always exerted, cognitive issues, brain fog, and increased heart rate. And then, of course, in some younger children, they actually have convulsions and CNS symptoms. But and then the other, of course, this is what occurs in menopause as well. Some symptoms of menopause include these things, but aren't necessarily limited to that. But the hot flashes, the night sweats, difficulty sleeping, depression, etc. And does the long COVID actually cause menopause? And the school is still out, although there are many who think it does. It can do it. And so would hormone replacement therapy help? And there's suggestion that yes, it may. It certainly will help with the hot flashes and all that. So it is recommended that they get hormone replacement therapy. What are the side effects of hormone replacement therapy? Well, there's an increased incidence of malignancies and some of that. So there's side effects to everything. So this is a group of patients which we haven't discussed much. The older patient who has long COVID and is forced into menopause and has other symptoms. And they mentioned the things that we should do. 7 hours of sleep is easy to say, hard to do. Good nutrition and exercise as always. They always say reduce stress. Of course, meditation and other things help reduce stress. So these are some final thoughts. Any other comments on that? Next week, we're going to have a presentation on chronic constipation, which is something that is common for people at older age groups. And so Dr. Eberhard, who's a colorectal specialist, is going to be talking to us about that. That is a topic that I think is timely. It's really surprising to me how many patients who are over 60 who have had chronic constipation at one time or another. And that's because they don't have Darryl's diet. But anyway, Darryl, you want to make a comment?
Yeah. For years, you've been telling us about meditation, and you haven't got a lot of co-signers outside of John Buchanan talking about yoga. And I'd like to be a co-signer. You know, we talk about exercise, diet, and sleep, but I would say that meditation has to be the fourth pillar of health, and it's not just religious. It's a good health and medical practice because it can reduce areas of anxiety, chronic pain, depression, heart disease, that's the number one killer of Black folks, and high blood pressure, which contributes to heart disease. And to get the most out of meditation practice, should be aiming at least once daily. Doesn't have to be lengthy or detailed. As little as 5 minutes a day can be beneficial.
Thank you
So
for
everybody
that.
get on the meditation train. Get on the Dr. Callender meditation train.
I'm on it. I'm on it already. I'm meditating.
So you say a prophet, it has no honor in his own country. Well, you got some honor today in your country.
Thank you. You give me honor every day, so I appreciate it. Just another instance of you doing so. Thank you. So look forward to seeing you guys next week. Tell your friends that we're going to be talking about chronic constipation. They may want to tune in and get some tips. And also that this doctor's a rectal specialist, you may want to see her. Elizabeth, you had something to say?
Oh, well, I agree. I stand for the ladies. you know, as a coach, I have 8 pillars that I encourage. Meditation is the heart of it. I even had one client, today is Thursday. Okay, I had one client Monday, and I was telling her about the pillars that I said, it's like a house. My father built our house. So it's like a house when you're building the foundation. If you don't put the right foundation under that house and the pillars begin to fall, you end up with a house that crushes. And so I stand for the ladies, as a wellness coach, it's nutrition, it's exercise, it's sleep, it's stress, it's high quality supplements for me, okay? Meditation and me time. And so when you switch it around, it has to be meditation first, and then everything else flows.
Carol, you want to say something?
Yes, I'm going back to when the medical students had a choice of either coming to the lecture or looking at it. I think our society, until they start mandating that you have to come to class, same thing is happening in our churches. Preachers do not like preaching to empty benches, even though we have a lot of the congregation looking on Zoom or streaming. They would rather see people out there to give them some type of feeling. And that goes with people. You don't like to talk to yourself in an empty room. So the lecture is really beneficial for everybody if they come in there mentally and physically. So until the medical field and educational arena and churches start requiring, and stop putting it on Zoom, stop streaming it, then they'll have to come and hear it. But as long as you got streaming, it's just like asking a child, you want to go to reading or you want to eat lunch? Boy, just say, I want to go to lunch. Or you want recess, or you want to take math. They're going to say, I want recess. Until our people after COVID decide they're not going to make it easy for you. And if you want to, you're going to have to come out in person and etc., like we did before COVID. That's
well,
all.
thank you for that thought. And with that thought,